Hello, and welcome to Doc Talk Live. This is NorthBay Healthcare's way of reaching out to the community on important health information. With us today is Dr. Robert Baker. He's a physical therapist with NorthBay Healthcare, and he's going to be talking about your knees needs. Take it away, Dr. Baker.
Okay, thank you. And hello. So kids are going back to school, and as we drive around, we see quite a few people in parks, soccer teams back in action, baseball is still active, cross-country runners running by in groups, everyone walking their dog. So it's a good time to talk about knee health. A lot of people talk about their knees, and you hear comments like, "My darn knees," or "Oh, if I only had good knees." But today we're going to discuss that really it's not really your knee's fault. Okay, there's a team effect here between your ankle and your hip and your knee, and so we want to look at it as the whole leg, and not just the whole leg, but what's happening in your trunk as well. And then looking at that as a team, just like you would as a company or in your household, it's never any one structure. It's that collaborative team, and then that's how we're going to view it. And if you take a step back and just ask yourself, like, psychologically, what is the knee feeling? What's its day like? Because we all know if we're in a traffic jam, we're going to get stressed. And if we go to work and some people aren't working and you're going to get stressed. And I think the knee also kind of thinks, hey, am I getting help from my hip? Am I getting help from my ankle? Or are they not doing what they're supposed to? And then I have pain. And when that happens, then your knee communicates to you the only way it knows how to, and says, I'm stiff, I hurt a lot. So we want to listen to the knee. We want to think of it, as a valued member of the team. And let's start with the anatomy. Let's take a look at this knee. Okay. So this is a knee, outside, inside, and it's rather complicated. And in fact, if you were buying a car that had all these complicated structures, technologies, you'd be paying a lot of money for that car. Okay, this is an amazing piece of anatomy. So let's take a closer look. Okay, you have a kneecap. We all know about the kneecap, the patella. Okay. Pretty amazing. It allows your quadricep muscle to generate torque through 120 degrees of motion. Well, what does that mean? Well, it means when a field goal kicker kicks a kick 50, 60 yards, they're torquing using this quadricep muscle, and this kneecap gets the credit. So right away, you're looking at your knee and you're saying, you're amazing. And that's what we should say about our knees. We should say every day, hey, you're an amazing structure and thank you so much. All right, so this kneecap lives in this little groove here called the patellar groove. Now that is slick. Look at that groove right there. It's smooth. It's like a great home, a great bed, a great pillow, a great car, a great chair that you sit in. That kneecap wants to be in that groove. And when you step down a step or decelerate on a field, okay, that kneecap is going to glide right into that groove. And it's going to be happy because it wants to be there. And the pressure is distributed, and that's kind of where it wants to be. What else about this knee? Well, let's open it up a little bit and take a look. How about the famous or infamous ACL, anterior cruciate ligament? Now, we've all heard about that in sports. Some of our favorite players have ripped it, and they're out for a year in rehab. So that ACL keeps this bone here called the tibia from gliding forward. So if you're decelerating down a hill, hiking down a curb, okay, or cutting on a field rapidly, it's that ACL that's going to really decelerate this bone from going forward. Pretty amazing. PCL, posterior cruciate ligament. Okay, that's going to be the ligament running from the front to behind, this one right here. Hard to see, but that comes into play when your knee's hyperextended and someone hits into you and it stops it. So in that case, your posterior cruciate ligament is getting tense, keeping this bone from going backward, the tibia from gliding backward. So also amazing. Your medial collateral ligament, Steph Curry injury, keeps your knee from buckling in. Lateral collateral ligament keeps your knee from buckling out. Then we go to this wonderful meniscus, lateral meniscus, medial meniscus. And yes, we all know that they get injured, that they degenerate with osteoarthritis. But let's talk about some of the amazing aspects of your meniscus. They've got water that repels itself inside of this cartilage to create a hydrostatic shock absorber. Okay, again, if it's a car that you're buying, you're over $100,000 right for that vehicle, because come on, hydrostatic shock absorber, pretty amazing, the meniscus. Okay, so really, when we think of our knees, think of something that's special, it's amazing, each and every day. Treat it with respect, and really start thinking, is my team doing what they're supposed to for my ankle, knee, and my hip? Okay. So one of the challenges that we run into is evolution, okay? Mankind, humankind, we evolved over millions of years as marathon runners. We were marathon runners to hunt because we could thermoregulate, we could sweat, and animals really can't thermoregulate, they pant. So it didn't take long to realize that if you clanked and made noise and four-legged animals ran, they would eventually kill over and die, and hence that's how we hunted for millions of years. And then in the last 200 years, we became sitters, and we sit in chairs. And so the body hasn't had really a chance to catch up. But if you look at that as a runner, you're really developing very strong hip muscles and leg muscles and calf muscles. And your trunk and gathering, your core is working. When you sit, it's passive. Your core is turned off. Your hip muscles are turned off. In fact, there's literature where your brain doesn't even recognize that my gluteus maximus is even there. And so you begin to recruit other muscles like a hamstring or an adductor muscle group. So you totally change the muscles that you use to walk, to run, to do yard work. Okay, so that's one thing to consider, is that we've thrown our knees into this evolutionary twist that's not in their favor. There's a saying that, do you run to get in shape, or do you get in shape to run? Well, let's look at running. It's 3.5 times your body weight, slamming into the ground with 10 to 20,000 repetitions. I would say that you want to train to get in shape to be able to run. Let's look at walking. It's 1.5 times your body weight on one leg. And again, we strive for 10,000 steps per day, right? Or 5,000 or whatever you can do. But that's a lot of challenge. So I would say you probably even want to train a bit to walk down the street, to do yard work. You want to stay in shape. So we go back to our knee model here. All right, and the discussion now is, why do knees get injured? Well, one aspect of that is that there's force going through your knee. And if you wobble, if you notice that your knee buckles in with every step, okay, you're going to be weight bearing in your lateral meniscus, but maybe not so much in your medial because you're buckling in. So your body weight's now going through half the area, which means you have double the force with every step. So we all know about financial portfolios and 401ks, that if you're getting 12% a year, your money's going to double faster than if you're getting 6% a year. We all know that that's valuable. But the compound interest of degeneration is also a factor. And if my knee goes inward, and if I'm weight bearing on half the area, I'm doubling the depreciation rate or the degeneration rate. So that's a factor as well. And it's not just buckling in. You can buckle out with every step. Okay, and there's different reasons why that occur, but they're common reasons that we're going to discuss that you can do something about. So if I buckle outward, I weight bear more on my medial meniscus, and it degenerates more quickly. Okay, and with those motions, when you hit the ground, when you hit the ground, your leg rotates into the ground. Okay, So you start externally rotated, and your leg rotates into the ground. It starts with your foot, and then this lower bone, and then your femur rotates in, whereas your upper body is turning the other way. And so if you rotate into the ground nicely, with control, with good muscles, it's going to be very gentle to your knee. But if you rotate abruptly into the ground, no, your knee's going to not be happy, and it might communicate to you, I have some pain. It's trying to tell you that, hey, let's do something about it. Let's get some teamwork between your hip, your ankle, your trunk, and let's get stronger. Let's be able to control that rotation into the ground. Let's take an analogy. We're at a crab feast in Baltimore with the famous Maryland crabs, right? And you go in and you start to open a crab like this, and everyone laughs at you because they're going like, oh, you're not going to open a crab that way. Now you have to take that claw and you have to rotate and twist it really fast. Well, that is how you open a Maryland crab, right? But that's not what you want to do to your knees. You see, for your knees, you want to keep it nice and gentle with equal weight distribution through it. So that's a general theory. Quick and abrupt, not good. So with quick and abrupt, something else happens. It's called the viscoelastic effect, which is very mathematical and complicated. But here's what makes it uncomplicated. If you take a pebble and you throw it into water, the water deforms around that pebble and it's back to normal. So water is a perfect shock absorber in your meniscus, in your ligaments, in your tendons, and even in your bone. So slow and steady allows water to participate when you decelerate into the ground. Abrupt and fast with a twist, that really doesn't allow the water to participate. So then you shift from water shock absorption to solid shock absorption, and solids are brittle. And so people that walk and hit the ground like a ton of bricks, like let's say you're walking around your house and your glasses are shaking, and boom, boom, boom. And it's true. I mean, we hear ourselves walk. If it's really loud, you're hitting with a rapid rate of loading, and you're shifting from water to solid shock absorption. So you're going to get to the solids which are brittle, like cartilage and bone, parts of your ligament and tendon, and they get cracks, which is a part of the degeneration process. So the point is slow and steady, really good deceleration, rotating into the ground with strong hips that really control that rate of loading. So it's not just about the forces and getting rid of the wobbles, but controlling your rate of loading into the ground so you decelerate nicely. You can explode off fast. Athletes can explode. The faster the better. It's great. It's very healthy. But you want to load uniform with good posture, nice and slowly. So key point. All right, so before we get into exercise, let's look at some of the literature that's out there, because a lot of people, they're basically on the internet and you're pulling information from everywhere. So let me share with you a few of the key articles that really help develop some of the current trends and how to keep your knees at reduced injury risk, but also better performance as well. So this first article right here is by Scott Dye, D-Y-E, an MD, that's local. He looks at the evolution of the knee, and he looks at two factors that affect your knee health: repetition and load. So obviously, if you do enough repetitions of something, you'll break something. Or if you load it with more and more weight, 100 pounds, 200 pounds, 500 pounds, eventually something will break. So there's a repetition and load tolerance, but that also means there's a homeostasis or an equilibrium where you're safe. And it involves repetition and load. And each day, like if you're running 2 miles and you're doing okay, maybe if you took it to 4 miles, it wouldn't be a great idea. But the point of that, though, is that if you detrain, if you don't do anything, in theory, you wouldn't have injury, right? Problem is you decondition. And then at lower repetitions and lower loads, you do get injured. So there is a negative side to doing nothing, and that is your body's tolerance for repetition and load reduce. Interesting article. A second article is the Santa Monica Orthopedic Sports Medicine Foundation. It's the Prevent Injury and Enhance Performance program that was done with thousands of athletes, especially female soccer players, but all field sports, where they did dynamic warm-ups to activate your posterior hip muscles with a reduction in ACL injuries and other knee injuries, specifically showing up in the studies for female injuries being reduced. So the point is dynamic activation of your posterior hip muscles with hopping, with things that activate those posterior hip muscles, reduce injuries in field sports. Great information. It's being used worldwide. There's other similar programs internationally. This is pretty fascinating. This is a little study here by Richard Willey where he used mirror feedback in runners to reduce the pelvis dropping in female runners with kneecap pain or patellofemoral pain. And not only did he was he able to use the feedback of running to coach them to not drop your hip like this. He also coached them not to have the knee buckle inward. So they had a reduction of that knee bending inward and a reduction in pain related to patellofemoral pain. So you can actually get instruction on how to move better and do your training, with technique. And you can do that with biofeedback, as simple as a mirror or coach's eye on an iPad. So these are some interesting techniques that are new and emerging, that getting right to the function and improving how you move. This is a really important piece of work by Farocki, Pollard, and a group out of USC. There's other authors, where they looked at when you land in running, or do your exercises, if your trunk's forward, you're going to get more hip muscle activation, especially your gluteus maximus, which is very protective for knee health. So if my trunk is forward when I land, I'm going to get much better hip activation, and the more my muscles do, the less my bone and ligament does. So if I can get more performance out of my hip joint muscles, then I'm going to have less stress and strain on my knee ligaments, my knee cartilage, my knee bones. So really important article looking at trunk position with exercise and things that we should look at when we talk about exercises. Daniel Lieberman, a researcher out of Harvard, looks at the evolution of mankind. You can pull his name up. You'll get lots of great articles. There's other authors on that as well, but that's the evolution of how we evolved as marathon runners and how that relates to the development of the gluteus maximus and the posterior hip musculature. Really, really good information if you're into research. Chris Powers, biomechanical theories of the posterior hip muscle and how that's protective for most knee injuries. So ACLs, patellofemoral pain, iliotibial band syndrome, meniscal-based injuries. So training your posterior hip muscles really important. That's not to say that you shouldn't train your entire leg and your quadricep and your foot and ankle and your calf, all very important as well. But that posterior hip, really important, and it shows up again and again in the literature. And this is one of my favorites. It's an MRI study on the rotation of the femur in females with patellofemoral pain. And Rich Souza and others developed this study and found that the femur rotates inward. And when it rotates inward, it removes that wonderful patellofemoral groove. So let me get the model and show you what that means. So kneecap, patellar groove, femur. So if that femur rotates inward too much, so it's going to actually rotate this way, then your kneecap's going to land on this bone on the outside instead of in this nice groove, which would be the equivalent of you maybe sitting on your armrest every day instead of in your chair. I mean, really bad news, right? Your kneecap, 10,000 repetitions of running or even walking, it's going to get sore. And it's going to get more and more sore until finally you have patellofemoral pain syndrome, which is one of the most common injuries of the knee. So that femur rotating inward on MRI study, a standing MRI study, it's pretty brilliant research, because prior to that, everyone thought that tightness on the outside of the knee pulled the kneecap outward. And we did everything to reduce that tightness, but people still have patellofemoral pain. But in fact, what later studies have found is that weakness up higher in the posterior hip don't control the femur rotating inward, and so you hit the ground with a rapid turn in, similar to snapping that crab open. So basically, posterior hip muscles controlling your femur coming in, patellofemoral pain would reduce, and it's transformed how we treat patellofemoral pain syndrome. But it relates to other injuries as well. Control that femur rotating inward. This is just one specific to patellofemoral pain. So at this point, let's turn to exercises that you can do, and then we'll have some time to field some questions as well. Okay, so I'm going to grab a few things to assist us. All right, so we have these bands right here. Okay, this one's medium, this one's kind of aggressive. So you can put these bands on, your legs. So I'm going to see if I can get that on here real quick. And so we're going to get them so they're comfy, kind of spread it out a little bit if I can. And there we go. So now if I take my knees out, I'm going to use my hip abductors. And so if you're not mobile, post-operative, not moving around, can't do standing exercises, this will begin to get those muscles to work. But generally what we would do in the first phase of rehab is get your brain to recognize that you have these posterior hip muscles. So I may lie on my side and abduct. I might do that with my leg straight on my side. Another thing that you can do, if we can get a camera feed on this. Oops. Oh, here we go. I'll use this right here. So we'll see if you can see this. I can push into a wall or a table, which activates my hip muscle here on the outside, and then I can hold that squat position. Now, if I can't squat because my knees hurt, you can do it relatively straight, and there's absolutely benefit to isometrically holding because I'm activating these posterior hip muscles. My brain is becoming aware that I have them. If you're a runner, an athlete, your knee doesn't hurt, you can actually squat down with these. But the trick here is you're doing things to activate these posterior hip muscles so that your brain recognizes that you have posterior hip muscles. Because keep in mind, we're sitting 6 hours a day, some people 9 hours a day. And when that happens, the muscles in the posterior hip, they have proteins, actin and myosin that separate. Well, your brain no longer knows that they're there because they have no tonic activity communicating to your brain. So your brain shifts to your hamstrings, to your adductor group on the inside of your thigh. Those muscles will decelerate you when you hit the ground, but they will also rotate your leg in. Whereas the gluteus maximus will decelerate you and control rotation inward. So you have to first start with gentle exercises and activate your posterior hip. You can lay on your stomach and raise your leg up 20, 30 times. You can lay on your side and raise your leg up 20, 30 times. Those are activation exercises, easy to find on the internet, really good exercises. These bands are good, and there's a ton of exercises that you can do. So once you've activated your muscles, the next step is to maybe start to apply it to functional activity, okay? So what I'm going to do is something on a step box, which is going to be a little bit higher level. So let me show you this. Okay.
Maybe back by the bookshelf a little
Sure.
bit.
Yeah. All right. And 1 second while I tie my shoe. Sorry about that.
Never exercise with your shoelace untied. Right?
Exactly. Okay, so that one article we picked up by Faroki and Pollard was the trunk should be forward. So right here, my trunk's forward and I step back. That exercise here is going to activate my hip muscle. Just stepping back, I can have some dumbbells and reach forward. And these they're going to start to work you out. Another one that you can do is you can step forward with a little bit of hip flexion. So right here, I'm stepping down and back up. Chest up, really good. Allows my core to kick in. So I bring my chest up, elbows in, okay? And then I'm going to slide right down and touch and come up. Now, if I'm straight up like this, it's all quad. If I come forward a little bit, I'm getting my gluteus maximus and quadricep. Posture important in this area. If my knee hurts, I'm not going to do it. But if I'm getting ready to run and I've rehabbed myself and I'm going to be doing a lot of walking, these are the motions that occur when you run and walk. So you should be able to do 10 or 15 repetitions in good posture without your body wobbling, okay? If I don't like that particular type of exercise or let's say I'm not going to be running and I just want to train my body for walking and I want to get these side butt muscles, then simple step-ups like this are going to be pretty good. They're going to be pretty good. And you can go to both sides. And now you're getting some footwork where your feet are getting used to moving, integrating with your hip. Again, chest up, belly in, elbows in. Breathing, really important. Diaphragmatic breathing. Diaphragm's a core muscle. The gluteus maximus functions as a core muscle when you decelerate into the ground. The posterior glute medius functions as a core muscle. So your diaphragm is a leader of that. So if I take a longer breath in, longer breath out, chest up, I've inspired my core here, which will inspire the core of your hip, okay? Because they work as a team. So we're talking about teamwork in the hip to the butt muscles to the knee, foot and ankle. Foot and ankle have a core, okay? The tibialis posterior is a core muscle in the foot and ankle. So the key with those is that they work isometrically and they hold. So what I can do isometrically here is that, I can try and stand on one leg, and that's an isometric hold. That will force my hip muscles to activate. And then, I can try to control lowering off to the side right here. And here, chest up, lowering. I'm activating that side muscle right here. In fact, that was one of the exercises used in an iliotibial band study by Mike Fredrickson out of Stanford in 2000 that helped get IT band syndrome better, is that control of that pelvic motion right here, just coming down. Lots of repetitions of those. So you can functionally train your hip. Isometric is good. Posterior hip musculature, there's a lot of literature on the internet. These are just some ideas. If you're an athlete going out to run, some of these step downs are things that we would do with you. But, if you're 50, 60, 65, 70, 75, you still need to be able to activate your posterior hip muscles, and some of these exercises are relevant, for that age group as well. So.
Okay. I have a question on that. Is there a particular height that you want to get with your step? That looks like it's probably about 4 inches or so, or 5 inches.
That is a great question. So the question is is there an optimal height, for your step? So athletes are going to train at 6 to 8 inch heights. So if you're really tall, then you might want a slightly higher box, right? Because you have a longer leg. And so 8 inches to somebody 6'4" is like 6 inches to someone 5'8". But definitely if you're running, we train in that 6 to 8 inch height level. And you try to get that forward trunk position when you're using it. But that's if you're controlling those front step downs. Now, if you're 50 or 60 and you're walking around, you have to take curbs. So 4 inches, 6 inches would be relevant. It also gets you some footwork, so you learn how to pick your feet up. You might not do those forward step downs, but you can certainly do those side step ups. Okay.
We do have a question that came in during the chat here. Diane is asking, I have a friend who has soft tissue damage around the knee and has had therapy to build back strength, but has recurring pain in other areas of the lower leg, sometimes near the ankle, sometimes near the heel or the shin. Is she doing something wrong, or is this normal during a long recovery?
Okay, so we're talking about general approaches to the knee, but if you've been injured, there's a process involved where something is repairing. So you want to get in there, evaluate, and try to figure out what structure is compromised and why are you having pain. But in a very general sense, scar tissue is often a source of pain. And so getting some good fascial work and hands-on work, identifying densities in the soft tissue, having someone skilled to go in and release that can really make a big difference in terms of pain. There's the father of modern orthopedic medicine is James Sariax. 50, 60 years ago developed the theory, but basically scar tissue as being a primary source of pain. So that's one area to look at. Another area to look at is walking and movement with Coach's Eye or an iPad video program or just a video. And what's good about Coach's Eye, you can draw, an axis on it. And if your body is wobbling, if your knee is wobbling, those are areas of opportunity. I don't like to say that there's a problem. I like to say there's an opportunity. So what I would say with your friend, with the person that's having pain, is to maybe do a video of walking, of moving around, and really look at that video compared to someone that you feel walks really well, and say, is there a difference? And chances are there is a difference, and there would be an opportunity to control those forces that go through the knee and ankle. Okay, so those are a couple of options.
Okay. Does cartilage grow and adjust to the need of the knee as you increase distance in your running?
That's a great question. I think that the cartilage, from my experience and knowledge and studying, it does not regenerate, and there's articular cartilage and there's meniscus. So I don't believe there's enough satellite cells for that regeneration process. But it does have repair mechanisms such as type 2 collagen, which, if injured, can fill in. And there's different parts of the cartilage have different ways that it might repair based on its blood supply. So that's why you might consult, if you're injured, you might consult an orthopedic surgeon or a physical medicine specialist with an MRI to then tell you, what part of my meniscus or articular cartilage is injured and what's the prognosis in terms of that repairing with scar tissue or type 2 collagen. But there are other things that are done that there's injections now, biologics, and that's beyond my area of expertise, but it's a rapidly growing area and one that could provide some growth function within the cartilage and structures. And I would recommend pursuing that question with an orthopedic surgeon that does biologics or a physical medicine specialist. Okay.
You mentioned dynamic exercises and doing that before you run. Can you explain, what do you mean by dynamic exercises?
So the question is what are dynamic exercises before you run? And it's a really great question. A dynamic exercise are ones where you are activating your muscle while you stretch, like a forward lunge walks might be a dynamic exercise, or actually doing a deep squat down and up, or if your knees can tolerate it, hopping and landing and sticking the landing, and taking 5 or 10 hops. Dynamic is muscles are contracting while I'm working on range of motion and warming up my muscles, whereas non-dynamic or passive would be, I'm stretching my calf, I'm stretching my quad, my muscles are not activating. So you might want to stretch after your run, which is good. It's good to have flexibility, but before you run, more dynamic warm-ups, and it's easy to find on the internet, and that PEP program that I described has dynamic warm-ups for field sports.
You've talked a lot about athletics and people on this field of competition, on field sports, but what about older people who aren't really there for competitive exercise? What are some things that older folks can do to prevent knee injury?
Yeah, and there's a lot that you can do. So it's the same principle whether you're old or young. You want to activate those posterior hip muscles. So you want to do things to get to it. So if you were lying on a table and you could raise your leg up towards the ceiling, you're laying flat face down, that's going to activate your hip muscles. So as long as you don't have pain in your back, you can tolerate it. Those exercises would be valuable. But some of these exercises, like stepping up on a 6-inch or 4-inch step sideways, and then stepping down, as long as you can do that safely, moving lateral side to side are going to activate your side hip muscles, really valuable. That step box exercise where you take a 4 or 6-inch step and step backwards, those are exercises that I do with people that are 50 years or older. Post-op total hips, post-op total knees, those are exercises that we're doing to activate the hip muscles to protect that new knee or that new hip. Or to reduce wear and tear on a go-forward basis. So the sooner you start activating those muscles, the more they can do for you and the less your bone and ligament has to work. So it applies to every age.
How important is your diet to the health of your knee joint?
Well, I think it's an area of growing interest and extremely important. I went to a course that took me to the San Francisco Giants training room, and I was amazed that, you know, they actually have food groups for recovery, food groups for muscle growth, and then the athletes grab their food based on that functionality, and it's very important. So sleep, hygiene also showed up at that. So how much you sleep is important to how well you hydrate your joints, especially in the spine. What you eat for recovery, antioxidant diets with vegetables and fruits are going to be really good. They're going to reduce oxidative activities in the joint. Carbonated beverages with sugar, more than 2 of those a day, negative for osteoarthritis effects. So your weight, if your weight is up, your knees take more force. And it's not just the force of your weight. If your weight has a wobble, it's a force times a distance. So 10-pound loss could be 20, 30, 40 pounds less torque on your knee with every step. So a lot of factors interacting, but I think diet is an area of interest and very important.
Okay. Can you or should you run after a knee replacement?
That's a great question. The person doing that surgery knows that surgery the best, right? So your orthopedic surgeon is definitely going to be the person to ask. And most orthopedic surgeons they come from a sports background. So if anything, they want you to be active, but they're going to know the forces that prosthesis can tolerate over time. But I think it's feasible to get back to walking, 1 and 2 and 3 miles. Some people get back to hunting. Your first step on that total knee is to get full knee extension, because if you're compromising knee extension, all those things, walking, running, hunting, whatever activities you want to do are going to be difficult. So you want full knee extension at 0 degrees or more. You want to get 120 degrees or more flexion, but preferably 130. And so you want to develop your hip strength and your quad strength. Obviously if you're running and it's 3.5 times your body weight, your knee might not last as long, but some of that comes down to risk and reward in your life and what allows you to enjoy life. And I would not exclude it, but I would definitely have that conversation with your doctor.
All right. Well, we're past our time on our chat. I want to thank you for being here, and thank you all of you who tuned in. We will be doing our next Doc Talk Live on September 22nd at noon with Dr. Larissa Chartrand, who will be talking about preventive medicine. So thank you, Dr. Baker, and we'll see you next time.